Hello, my name is Jerica Singleton, and I partnered with Jenna Kelly to talk about ICU Prophylaxis, and we did this under the mentorship of Dr. Dell. So today I'm going to go into depth on deep vein thrombosis. And just as a little side note, March is actually Deep Vein Thrombosis Awareness Month. So you can kind of keep that in mind as we go through the lecture. Okay, the objectives for this lecture are to describe the formation of deep vein thrombosis, which should have occurred through the videos, recognize the importance for prophylaxis, identify appropriate DVT prophylaxis therapies, and design a DVT prophylaxis plan for a patient case. So, as seen in the videos, a DVT forms when a blood clot forms in the deep veins of the body. These deep veins are usually in the legs, and a DVT is also known as a red clot. As shown in the videos, it's primarily composed of red blood cells and fibrin strands, and that's because the red blood cells coagulate behind the valves of the veins and the deep veins of the body. And as they accumulate more and more, the fibrin begins to hold them together, so hold the red blood cells together. So that's why it's known as a red clot, because of its composition. The blood usually returns to the heart through help of leg muscle movement. This usually helps to push the blood back into the heart. But when a person becomes immobile, or it's hard for the body to help the blood return to the heart, this is when you have this optimal time for a DVT or red clot to form. DVTs can also be exacerbated if there's vascular injury caused by a surgical procedure, or if the patient is prone to hypercoagulability, and this can be seen in patients, in women that take oral contraceptives. Oral contraceptives kind of cause the red blood cells to become more sticky in a sense, and through the stickiness, it can also help to form deep vein thromboses. So it's important to maintain good health and good stamina and good mobility when you're on oral contraceptives. DVTs can present through symptoms such as swelling, pain, tenderness, warmth, discoloration of the area around the clot, so the leg can come really red and almost appear edemic with the swelling, but it'll be pain and tender to the touch. And DVTs can lead to pulmonary embolism, which is where the clot dislodges from behind the vein in the leg, travels up through the heart and into the lungs. And the capillaries in the lungs get so small that when the clot tries to go through them, it can't. So it forms a blockade. This blockade can lead to necrosis of portions of the lungs, which can ultimately lead to death. The combination of DVT and PE is known as venous thrombosis, or VTE. And we're going to talk about that a little later in a few slides. So we have a patient case here. BL is a 47-year-old African-American male who was admitted to your ICU this morning following a motor vehicle accident yesterday afternoon. BL was riding his motorcycle and was not wearing the appropriate clothing that he was supposed to be. He suffered severe burns over 10% of his body and is undergoing extensive surgeries to graft these areas. BL does not have health care insurance. His physician consults you regarding the appropriate DVT prophylaxis therapy for BL. So the questions are, what therapy option do you recommend? This includes dose, and administration route, and for how long should BL be on this therapy? So why prophylaxis? I wanted to start with the definition of prophylaxis just to make sure that there's no discrepancy between the difference between prophylaxis and treatment. So prophylaxis is the measures designed to preserve health and prevent the spread of disease, protective or preventative treatment. And that's from the Merriam-Webster dictionary. So that means that we're trying to do whatever we can to preserve the health of the patient. Treatment, on the other hand, is when the patient already has a disease and you're attempting to revive them to their normal stature or to their return them to their healthy manner. So today we're focusing on prevention of DVT rather than treating one that's already been formed. There's a lot of varying data out there that talks about the incidence of DVT formation. And I think that this is because of the difference in DVT detection, definition, and diagnosis. But all in all, without prophylaxis, DVT incidence can occur anywhere from 13% upwards of 60% of patients that have been admitted into the hospital. Prophylaxis can help decrease this to between 6 to 21% incidence, which is phenomenal that there is an option out there to help prevent what could be a life-threatening disease or event. The epidemiology of DVT is that, again, there is varying data on this one. I found that approximately 350,000 to 900,000 patients develop VTE, which is the venous thromboembolism, which is the combination of DVT and PE, and 2.5 million patients can develop DVT annually. And over 100,000 plus patients die of VTE annually, and that's because of that necrosis of the lungs and the inability for the blood to travel through the lungs, get reoxygenated, and travel back throughout the body. This is a very staggering number considering that there are therapeutic options out there available to help prevent this. But a lot of these patients don't know that they have blood clots in their legs, and the time between a DVT dislodging and becoming PE can be very short in some patients. And about 10 to 30 patients who survive their first VTE episode will develop another within the next 5 years. So that goes back to the therapy. Once someone has had a VTE, it's important to treat them in order to help them not develop another one. But today we're going to focus on prophylaxis, like I said. So evaluating the risk of a DVT. There's two scoring factors that I found. It's the Caprini score and the Padua score. And really, both of these are more just for general healthy hospitalized patients. Caprini risk score is more for general surgery patients, while Padua score is for your non-critically ill patients that are in the hospital. But I wanted to include both of these so you can kind of sense of who's at risk for a DVT. The Caprini risk score is shown on the right-hand side, and it's a very long, thorough evaluation, and in the different section you score different points, and every point when added up can indicate your risk of a DVT. 0 to 2 can indicate low risk for DVT, but honestly, when I took this, I scored a 1. So it's like I'm already almost at a low risk for a DVT. So pretty much any of our critically ill patients are going to be at a moderate to increased risk for DVT. It's kind of the nature of the beast. Age is going to lead to it. Immobility is going to lead to it. All their comorbid diseases are going to lead to their increased risk for DVT. So prophylaxis isn't really a question in our critically ill patients. It's more of just when are we going to start it? Let's start it as soon as possible. The Padua prediction score, high risk is greater than 4. It kind of runs along the same lines as the Caprini score, where you get a certain number of points for whatever you may present with. And again, it's not hard to get 4 points. Some risk factors include being over the age of 40, smoking, being bedbound, which is what our critically ill patients are most likely going to be, having comorbid diseases, having chronic lung disease, heart failure, serious infection, our sepsis patients, recovering from surgery, irritable bowel disease, cancer, varicose veins. So, like I said, essentially everyone is at risk for a DVT if you're immobile. So our prophylactic options. Some of these aren't necessarily applicable to our critically ill patients, but I wanted to show them here. The first one is movement. This isn't applicable to our DVT patients because they are immobile. They most likely don't have a very good range of motion. But this is very applicable for people that are on long flights, anywhere upwards of 5+ hours, or just people with sedimentary lifestyles. It's important to keep moving because, like I said, and like the video showed, that the muscle contractions in the leg help return blood to the heart. So let's, for the remainder of the lecture, kind of focus on keeping your legs moving. So some things that I read from the CDC are to raise your heels while keeping your toes on the ground. So let's try that. And then raise your toes while keeping your heels on the ground. So do about 5 reps of the first one, then 5 reps of the second one. And then 5 reps of tightening and releasing your leg muscles. And just kind of do those for the rest of the lecture. And that is a motion that will help prevent blood clots from forming when you're in sedimentary lifestyles or when you're sitting down for a long time, like you usually do when you're studying. So make sure we keep moving and take breaks and go for walks. That's not always available to people on flights, but it can be very helpful for us as students. The next one is compression stockings. This one's not as applicable to our critically ill patients either because it's more for general med patients and patients that have been discharged. But compression stockings are a stocking that applies a certain amount of pressure on the leg to help push the blood from the legs back to the heart. It's not a continuous motion. It just kind of provides that pressure to help keep the veins constricted and pumping to get the blood back to the heart. They come in a variety of different pressures and sizes and colors for cosmetics. They can go all the way up to your thighs. They can stop at your calves, or they can stop at your ankles. And these ones are usually prescribed by physicians, and they can also be used for prevention or treatment for varicose veins. And I do know that some pharmacists wear compression stockings in order to alleviate the pressures of being on their feet all day. So kind of gravity's working against your blood pumping back to your heart, so they wear compression stockings to help with that motion. The next 3 things we're going to go over throughout the remainder of this lecture. SCDs, or sequential compression devices, are mechanical prophylactic treatment therapy, or not treatment, our mechanical prophylactic options. Our pharmacological options, which include unfractionated heparin and low molecular weight heparin. Fondaparinux is on there. It's not used for our critically ill patients, but it is used for our general med patients for DVT prophylaxis. So I wanted to include that on this slide. However, I'm not going to really go over it because it's not for our critically ill patients. And vena cava filters. This is more for our pulmonary embolism prophylaxis, but I want to include it in this lecture just so you're aware. So sequential compression devices. These, according to the chest guidelines, are used for critically ill patients with a high risk of bleeding or that are currently bleeding. And then once this risk for bleeding goes down or the bleeding stops, then it's important for our critically ill patients to switch over to our pharmacologic options. But SCDs are used very commonly in the general med floors as well in order to help keep blood flowing and prevent the venous stasis. SCDs work by inflating and deflating with air in the lower extremities, mimicking muscle activity. So the same way movement is important for helping to return blood to our heart, these mimic the movement for people that are bedridden. And SCDs in a lot of different sizes. They can be strictly around the foot, they can be calf or knee high, or they can be thigh high. Each compression lasts about 11 seconds, and then it depresses, and then it compresses again. So a complaint is that they can be uncomfortable, they can just be annoying, but the biggest complaint is itching. You have these plastics around your legs for a long period of time, compressing and depressing, and just causing a friction on your legs. So a lot of patients complain about itching. And I found out on a nursing consult website that you can put things like baby powder or powders in between the legs and the device in order to help eliminate or reduce this friction to bring down the incidence and inconvenience of the itching. So just something to be aware of. It might be something that the patients complain about. They probably won't complain to the pharmacist as much as the nurse per se, but just in case the nurse calls you and was like, what can I do about this? You can say, oh, baby powder. So anticoagulants. This is the bread and butter of our DVT prophylaxis. And according to the chest guidelines, the most effective pharmacotherapeutic option for DVT prophylaxis through anticoagulation is the unfractionated heparin and the low molecular weight heparin. Like I said, fondaparinux is also an alternative, but that's for more acutely ill hospitalized patients. It's important to understand that ICU prophylaxis for DVT varies from post-surgery DVT prophylaxis than our critically ill DVT prophylaxis. So also take that into consideration when we're going over things such as doses and routes of administration. They are different sections of the guidelines that in order to provide different therapies. So first off, let's refresh on how our heparin family anticoagulants work. On the right side is the coagulation cascade. And just to refresh your memory, there's the intrinsic pathway and the extrinsic pathway. And those are kind of caused by two different sources, but meet together at factor 10A. That is where the two pathways converge. So that is probably the most important coagulation factor that would lead to the blood clot formation of whether or not you had a trauma or if there was a abrasion in a vein or something like that. So factor 10A along with factor 5A activate prothrombin, which prothrombin then turns into thrombin, which in turn converges fibrinogen into fibrin. And the fibrin strands are what form the clot. They are the strands that hold together the red blood cells and other components of the clot. But like we said before, our DVT clots are red clots, so it's mostly fibrin strands and red blood cells. So what heparin does is heparin accelerates the activity of antithrombin 3. And this is the molecule that's responsible for inactivating thrombin. So if you inactivate thrombin, then you inactivate the rest of the coagulation cascade, because thrombin can't help convert fibrinogen into fibrin. So you help prevent the clot in that the fibrin cannot form and the strands cannot clump the cells and platelets and other factors and things together. Heparin is used prophylactically. It does not break up clots. It solely prevents the formation of clots. That's important to understand because there's different pharmacotherapeutic options that help break up clots. But since we're focusing on prophylaxis, we're going to focus on heparin. On the left side of the screen is a imitation of unfractionated heparin versus low molecular weight heparin. And the unfractionated heparin is a rare polysaccharide chain that binds antithrombin and can in turn inactivate factor 10A or factor 2A, which is also the thrombin. And unfractionated heparin also can affect other factors throughout the coagulation cascade and can actually bind to things like platelets and other cells in the body to prevent the clot formation. Low molecular weight heparin, on the other hand, is a shorter polysaccharide chain and cannot inhibit thrombin the way unfractionated heparin does through the binding of antithrombin and thrombin. It can only inhibit factor 10A activation through the binding of antithrombin. In turn, this low molecular weight heparin has a higher affinity for preventing the activation of factor 10A because of its selectivity when binding to the antithrombin for the factor 10A. Regardless, both inhibit and prevent clots, and I did some research on which one is more effective than the other, and the biggest thing between these two is the number of administrations per day and cost. Heparin is a lot cheaper than low molecular weight heparin because it's been around a lot longer. And but both show similar efficacies, and we'll talk about how many administrations per day they have coming up. Okay, so for unfractionated heparin, the CHEST guidelines, along with some other trials, recommend low-dose unfractionated heparin for DVT prophylaxis. So the biggest things that's going to happen with this low-dose unfractionated heparin is going to be the route of administration and the monitoring. That's different than from what we normally expect. So low dose is 5,000 units subcutaneously twice a day. Now, there is some debate out there between twice a day versus 3 times a day. However, there has not been a head-to-head trial between the two times of administration. So it's easier for our nurses to do twice a day, and because there's no head-to-head trial, this is what is recommended. However, if your patient does require 3 times a day because they are at an even higher risk, then you can take that into consideration. The nice thing about unfractionated heparin is that there's no renal dose adjustments required. So if your patient has AKI or advanced renal disease, you can give them heparin without requiring adjustments. However, unfractionated heparin and low molecular weight heparin are not dialyzable, so it's important to take that into consideration. Monitoring, there is no recommended monitoring for the heparin alone. Normally when you think heparin, you think of monitoring with APTT, But because we're doing the low dose infectionated heparin and it's being delivered subcutaneously, the APTT won't detect it as effectively as it does when you give heparin IV. So it is not recommended. It is actually, in some trials, it was called a waste of time and money to monitor APTT. You can monitor for DVTs through ultrasound. However, it's not recommended to do free ultrasound DVT monitoring just because, again, of the time. Some adverse drug events is the heparin-induced thrombocytopenia, and essentially if your patient undergoes HIT, that is a failure of therapy because a VTE episode has occurred. So your patient has developed a clot and it has become a pulmonary embolism and the heparin's not working. Also, the reversal agent is protamine. It's 1 milligram per 100 units IV bolus, which essentially turns into a 50 milligram IV bolus. However, for the same reasons why we don't use APTT, because of the low dose and the subcutaneous administration, the protamine will not work as effectively or as quickly as it would if you were giving the heparin IV. So it's kind of a give or take again with the protamine, whether or not it's vital. So for our low molecular weight heparin, there's two that the trust guidelines recommend, and that is the enoxaparin and the dalteparin. The enoxaparin is dosed at 40 milligrams sub-Q daily. I know sometimes we think of prophylaxis as alternatively 30 milligrams subcutaneous BID. However, for DVT prophylaxis of critically ill patients, it's recommended to do the 40 milligrams sub-Q daily. Enoxaparin does require a renal dose adjustment. If the creatinine clearance is less than 30 milliliters per minute, it does go down to 30 milligrams subcutaneous daily. But also, if the creatinine clearance is going that low, you may want to consider switching to a different therapy, such as the heparin. Monitoring, like with the heparin, there's no routine specific monitoring required. However, you are going to want to monitor renal function to either increase or decrease the dose. Some adverse events are going to be bleeding and hemorrhage. We are preventing clots from forming in the body, so bleeding or hemorrhage anywhere in the body is a potential. The other one is fragment or dalteparin. This is a good low molecular weight heparin as an alternative to Lovenox because it doesn't require renal dose adjustments. It is dosed at 5,000 units sub-Q daily, which is the same as the heparin dosing, so that could be easy to remember, but also easy to confuse. Again, no monitoring and the same adverse events because we are preventing bleeding. I looked for trials comparing which one of these is more effective, and they're about the same. No trial really could say one was superior to the other or one was more effective than the other. So really, the difference between these two comes down to hospital protocol and whichever one's cheaper. Enoxaparin has been shown to be cheaper, but like I said, it just pretty much comes down to hospital protocol. You can also use protamine as an anecdotal agent for low molecular weight heparin. However, it does not work to as great of an effect as it does with the IV unfractionated heparin and the sub-Q unfractionated heparin as well. This is a breakdown of just where you can go. Again, it kind of depends on bleeding risk as to whether you go for mechanical prophylaxis or pharmacologic prophylaxis. If they're at a high risk of bleeding or they are currently bleeding, they're going to want to go mechanical. And when that bleeding risk goes down or is decreased, then you switch them over to pharmacological. If they're at a low risk of bleeding, you can do pharmacological. It really just varies patient by patient and your clinical professional judgment. Prophylaxis should occur for 6 to 10 days, but really this again is going to depend patient to patient. Evidence has suggested that DVTs can form outside of the 6 to 10 day window. And if your patient is in your ICU for longer than 10 days, you're going to continue to prophylax them. So really it's a by case basis. So vena cava filters. Vena cava filters, like I said, are mostly used for PE prophylaxis. However, they can be used in patients that have a contraindication to pharmacotherapeutic anticoagulation and mechanical prophylaxis is not working. So what a vena cava filter, it's a small metal filter that goes into the inferior vena cava, and it traps clots that may form and break away from the valves in the deep veins and prevents them from getting to the lungs. There are permanent vena cava filters and retrievable vena cava filters, and they do require a lot of monitoring because you are trapping clots, and that may form an even bigger clot. Like I said, they're used in patients that are contraindicated to anticoags or that have failed anticoag trials. Some contraindications include hemorrhagic stroke, recent neurosurgical procedures or other major surgeries, major or multiple trauma, acute internal bleeding. Pregnancy is kind of an iffy category because both low molecular weight heparin and unfractionated heparin are safe in pregnant patients, so that really varies from patient to patient. And so vena cava filters aren't commonly used. They're not recommended for our critically ill patients unless unless needed on a very dire basis. The following slides are just references, and I thank you for listening to this presentation. And look forward to a fun and exciting day on Friday. Thank you.